Yeah, so good morning, good afternoon, good evening, everyone, wherever you are in the world. So closed captions are being automatically generated, and you can just press the CC button at the bottom of your screen if you want to access those. There's also a Q&A box, so if you have any questions for the speakers, please put them in there, as in the second half of the webinar, we'll have a discussion, and so we'll answer the questions then. Also, if you can't see the slides, then please just exit the webinar and then come back. Sometimes we've had that happen, and it's just resolved by exiting and coming back in. So my name's Sarah Bourdin, and I'm delighted to welcome you all to the final webinar in MeSH's webinar series, Strengthening Routine HIV Data, a Female Researcher's Perspective. So the aim of this series was to discover the perspective and work of brilliant women within the HIV field. And these women discuss their contributions to strengthening the understanding, collection, analysis, and use of routine HIV data towards the aim of accelerating and tracking HIV decline in sub-Saharan Africa. And so this is hosted by the MeSH Consortium, which is part of the London School of Hygiene and Tropical Medicine, and it aims to maximize the potential of data routinely collected through HIV surveillance and service delivery platforms, as well as provide timely information on key outcomes in relevant populations. So yeah, if you want to hear more about our work, just in general to hear more about how these talks go further, please make sure to follow us on our Twitter and on the website as well for updates just on the series and on what MeSH does. So my colleague Tom will just put those into the chat box now, so you can follow those links. And then, thanks Tom. And then, yeah, so it gives me great pleasure to introduce Dr. Shona Dalal from the WHO, who is going to be presenting our wonderful final webinar, and we're very honored to have you finish up this series, Shona. So without further ado, I think I'm going to just hand it over to you, and you can get started if you're ready.
Great. Thank you, Sarah, for the warm introduction, and I'm happy to be here. Thanks to you and to Brian for the invitation to speak and talk to you a little bit about what we're doing at WHO on improving access, use, and strengthening routine HIV surveillance systems. So I'll be talking to you. I hope you can see my slides.
Yeah, we can. They're just not in presentation mode, though.
I've clicked it. Let me just try again.
Oh, yeah, there we go. Yeah.
All right. So I'll be talking to you about some of the strategic information guidelines that WHO puts out, and as well as sharing some of the digital tools that we're developing to try to improve routine surveillance. So a brief outline of my talk today is to first give a little bit of background and on the utility of person-centered data, why we need it. I'll then talk a little bit about the consolidated guidelines on person-centered HIV strategic information that we're developing currently. I'll talk a little bit about SMART guidelines and the digital adaptation kits we're developing for countries, and also the facility data use materials that we have. And then finally, I'll end with our exciting DHIS2 HIV case surveillance tracker, which really is a fundamental tool for strengthening routine health facility data analysis and use. So I want to start by saying that I think more and more as we're going forward, harnessing the power of routine programmatic data is critically important. Measuring trends in key indicators for the HIV epidemic has been important over the last many decades. And as you can see in the graph on the right, we have good statistics and numbers on, say, coverage of ART over time, on information from large population-based surveys about who's being infected, which age and sex groups, which geographic regions are of importance. But really some of the critical questions are, who amongst these groups of people who, when we're looking at ART, who is being missed, who is being lost to follow-up, why is that the case? And these large statistics and numbers really can't get into the details of that. And ever more, as funding has stagnated and the response is changing, there's a request and desire for ever more granular data. And really the focus is on now public health action in near real time to emerging trends that are seen at the local level. And while we think that, these efforts are important, how to do them is the critical question. And so really having something that has wide geographic coverage, is sustainable, and that can link to other data sources is critical. And we really think that routine programmatic data that is used for clinical care can be used appropriately for surveillance. It's the approach that's used in many high-income country settings, and we see no reason that that should not be the case for other low and middle-income settings as well. So what are the challenges with the status quo? And this perhaps needs no introduction. Paper registers, which are often in use in many settings, do not support quality of care. They're burdensome and tedious for health workers. There's little value added to them for their own work. Often these are data that are collected and reported up for use at the national level. Often based on funding challenges or other issues, they're inadequate tools. They're sometimes stockouts of paper forms. And then we also have mistakes that are made during aggregation of from paper-based form, where you're trying to add up, how many people started ART and how many of them were female and how many of them were male and what was the age distribution. And so this is just, it just creates a huge burden. And as you can see on the right with the two cartoons in this photograph, people are overwhelmed and burdened by enormous amounts of data reporting, which is what we as epidemiologists and others who are decision makers need to be able to prioritize and target their responses. So really, the data and content standards are also difficult to introduce into these legacy systems. So there's very many challenges associated with it. The other issue is that we have different routine health information systems. And this often stems from the fact that the world of HIV is funded by many different donors who have different data systems and different reporting requirements. And so often these vary based on which districts are or are not supported, who is collecting what information. There's often a mix of national systems and non-governmental organizations. And some data are reported to the ministries of health, others may not be, for example, particularly in private facilities. And then there are often different systems for different populations. Key population programs sometimes have very specific reporting and very specific measures that aren't in place, say, for the general population. And then, of course, we have different systems for different diseases, even though these might all be related, for example, HIV and sexually transmitted infections. And across the board, countries are at different stages of digitization of their routine health information system. So there's a maturation pathway as countries move towards increasing digitization. So trying to make all of this come together is what we're hoping to do with the shift to digital health data systems. So the idea behind this is to use digital tracking and decision support systems to first track health services and the status of clients, to have decision support prompts and algorithms to guide the quality of care. So for example, somebody's missed an appointment, or that this person is due to come in for X service or hasn't accessed treatment for an STI. And then finally, to have automated aggregation towards indicators and other secondary data use needs and metrics, such as the fact that we use at the global level when we're trying to see how countries are doing and measure metrics across different countries to see how the HIV response is going globally. So some of these systems include, OpenMRS, the DHIS2 tracker, which I'll talk about, and there are many, many, many others. But the idea is to get away from this one where you're trying to add up totals from somebody's handwritten notes and move towards digital data systems. So I'm going to first talk a little bit about our strategic information guidelines that we're currently developing. And I have the distinct pleasure of working with Dr. Brian Rice from your school, who has had a wealth of experience in developing routine data systems in the UK and in other countries as well. And so we are working together to try to emphasize the importance of these guidelines and what can be achieved with routine surveillance from programmatic data. So the current WHO strategic information guidelines there are two. The first is the 2017 guide on person-centered patient monitoring and case surveillance. So this was really focused on HIV diagnosis and treatment. It included individuals, once they tested positive for HIV over time, to see what are the minimum criteria and data that we need to collect on them. It didn't include prevention or any follow-up of people who were testing HIV negative. On the right, we have the aggregate level data for people who, for aggregate indicators. And so these, we had 15 core and 40 priority indicators that cover a huge range of prevention, care, and treatment indicators, including ones from surveys where there weren't good routine data. So where are we headed now for these new guidelines? So the idea, again, is to strengthen routine surveillance systems to monitor trends over time in two sets of somewhat separate people. First is the people living with HIV, which we already do. And the second is individuals at risk identified through prevention or referrals from related services, such as, say, contraception or sexually transmitted infections. And the goal is to improve, first, the quality of healthcare services that are provided. And the second is the quality of data that are used for surveillance and program management. And the idea here is that you would have a minimum data set. This is the core piece of information that you need to be able to track to understand the situation on HIV on the ground, and from those then to derive aggregate indicators. So really to try to simplify this process. So here's what it would look like. You would link facility level data. So here in the green, where you have a woman who's taking in information from a client or a patient in a healthcare setting. And that individual level data that would be generated at the point where services were delivered would then be aggregated up for calculating data indicators at the subnational or national level for further analysis by people working in strategic information. So the principle behind this is to collect data once, but use it many times. So we're not having to, every time you need a new disaggregation or you say, oh, here, maybe we need to look a little bit more in this key population. You don't have to go back and start adding those totals up again. So here's an example where we have people living with HIV who are on ART. At the facility level, you would use this information to forecast ART supplies, to allocate healthcare providers, and for basic patient management. At the regional or district level, then you would start looking at service burden across facilities. What is the progress towards local targets? How are resources needed? Where are staffing levels short? At the national level, you could use the same information to look at national targets. You could use it for inputting into modeling or other estimates, and as well as for looking at resource needs. And at the global level, of course, we would be using it to track achievement towards targets and to our global goals, such as the SDGs. And so just to emphasize here, the point is that at the very base of this data pyramid, you would have patient care and patient monitoring, or in the case of prevention services, client care and monitoring. And you would need a huge amount of data there to first provide them the services, to make sure they were accessing the services they need. And then by aggregating it up, you would need less data, but you could use that same information for program management and for program monitoring at the national level, as well as for global monitoring. So where do digital approaches and systems come in? So we know that healthcare systems have a number of challenges, and some of these have digital interventions that can assist in in solving these issues. But in other places, of course, digital solutions are not going to make a difference, and we need other approaches. But just to give an example of three, so if we start here on the bottom row, if you're looking at, say, the loss of follow-up of clients, so that's sort of a challenge to understand who is being lost and why. And at the digital solution, what you could have is you could first have targeted alerts and reminders to remind people that they have an appointment, and then to be able to track longitudinally clients' health status, to be able to know when they last picked up their pills, when is their next appointment, how many days has it been since their last appointment. And the applications that this could come from would be, for example, these client communications applications, medical records, and so forth. In the middle row, if you look at the lack of access to information or data. So for example, in the routine health information system, people may not know, who is being missed or why. And you could be able to put in a digital system that would tell a healthcare provider, give them a line list of whose appointment is coming up, who's missed it after a certain number of days. And again, that would come from a health management information system. It also could come from an electronic medical record, but really those are better placed to be put in some sort of an aggregate format. And at the top, we have an insufficient supply of commodities. And that sort of relates to some of these pieces where you should be able to manage the inventory and distribution of health commodities, identify stock levels before they're out, and then be able to address needs as they come up. And so those are logistics management information systems, and they really should be now paired with the client information systems, the health management information systems, so they're all working together to provide the best information process available for decision makers. So where are we going with these guidelines? I want to give you just a flavor for what we're including. And here's an example for prevention. So for prevention, it's been a challenge for many years, and it's in terms of how to measure it, who received prevention services. And so what we've had is a comprehensive list of prevention services that includes HIV testing, STI testing and treatment, other sexual and reproductive services, condoms, post-exposure prophylaxis, pre-exposure prophylaxis, needle and syringe programs, drug dependence, voluntary medical male circumcision. So the idea is to start including regular monitoring of individuals who are receiving these services over time so that we can better track who is using them continuously, who is in need and not getting them. We're also planning to now incorporate comorbidities for the first time. So this is that we're focusing in particular on sexually transmitted infections, hepatitis, and cervical cancer. And the other part here that's interesting is as we expand data collection beyond just people living with HIV in surveillance and start including individuals who are accessing prevention services, this is a real opportunity to collect additional information on related conditions. Each of these three is associated with HIV, and which is why they've been selected. And there's really for each of them, STIs, hepatitis, and cervical cancer, there's a real critical need for better programmatic data. And ultimately, as we talk about integration of services, and it's following the one person who has many conditions, this is a step in that direction. On the right, I've put up a slide of the population attributable fraction of women with cervical cancer living with HIV in 2018. And this is an analysis we did last year. And what you can see is that the burden is the highest in those countries with high burden of HIV. And the reason is that women living with HIV have a 6-fold higher risk of getting cervical cancer than women without HIV. And so providing these services to women living with HIV is really a critical priority. And with the new effort to eliminate cervical cancer by WHO globally, then this is something that we have to start seeing at a programmatic level. So just taking the cervical cancer as an example to illustrate this point, the three traditional, I'm going to call them traditional aggregate indicators that we've used for cervical cancer, and these have just been agreed this year for what will go into our global monitoring, are three very simple indicators. The first is the number of women living with HIV who were screened for cervical cancer using any screening test. And that's because there are a number of different screening tests and they all have different frequency at which they should be conducted. The second is the percentage of women who were screened positive, who received treatment. And the third is the percentage who had suspected invasive cancer who were treated within the last 12 months. So after much discussion, these were the three indicators that we were able to come up with. Now, taking this new approach to routine data and having a discussion as part of this guideline process, this is now what we could potentially collect on cervical cancer. So these are sort of the routine data potential indicators that could be collected as part of a minimum data set on women living with HIV to ensure that they are screened and that we know who is being screened, by what screening test, were they triaged, because this is the one of the WHO recommendations is that women living with HIV need a triage test. And did they receive treatment? When was it? and how often in their lifetime were they screened. So above the blue line here are the two traditional indicators, and down here at the bottom are these proposed aggregate indicators that we could look at for cervical cancer. For example, what was the median time between the first and second lifetime screening test? What was the median age for their first in a lifetime screening test? You know, our recommendations say that women living with HIV need to start being screened at the age of 25. So these are all really a new shift in thinking on what we can do. And these are just the indicators on cervical precancer. If you look at, we have the exact same number for the cervical invasive cancer. And so it's really shifts what we can collect, what we can understand, and what we can use for direct action at the facility level, as well as at the district and national level. So moving now to talk a little bit about the digital packages that we're using to support person-centered HIV data collection and use. And I've highlighted here these tools and guidelines that we have. In the top are the guidelines. So we have on the 2020 guidelines, these digital adaptation kits, which I'll talk to you about briefly, and then the DHIS2 HIV case surveillance tracker. And then all these will come together in the new consolidated guidelines that we're working on for release next year. So digital adaptation kits, what are these? So we know that as it stands, the WHO guideline process is a long time to basically implement and understand, review the evidence, and to come up with a recommendation for what we should do in a clinical setting. So that is, say, you know, start treatment immediately after an HIV diagnosis. All the evidence has to be reviewed. It has to go to an expert group, a guideline development group who will review it. Then it goes to an internal guideline review committee. And finally, we put out a global guideline. So that's the start here. And following that, ministries of health adapted, implementation technology and partners implemented. It finally gets to the workforce and then finally to the users. And often they don't get integrated quickly. It's resource intensive to adapt and scale. And it's often difficult to update or adapt with fidelity to the original guidelines. Sometimes guidelines are very detailed and specific about what you need to do. For example, those cervical cancer guidelines say that for women living with HIV, you can use HPV DNA testing using a triage test starting at the age of 25. So there's a lot of detailed information that is packed in there that needs to be interpreted and adapted appropriately. So we at WHO envision a future where everyone in the world can benefit fully and immediately from clinical public health and data use guidelines. And the way we're doing it is through these computable guidelines. So they're a new approach to representing and implementing clinical public health and data recommendations in the digital age. So at their heart, they are a comprehensive set of digital health components. So these include standards, they have code libraries, algorithms that basically transform the guideline adaptation and implementation process to preserve the fidelity of the guidelines and to accelerate their uptake. So just a quick word on what they are and what they are not. So computable guidelines are not digital apps. We have a lot of apps. So for example, we put out a guideline on HIV treatment and there's an app version of the guidelines. This is not that. These are a pathway or systematic approach to digitizing the guidelines within like computable systems. They're not bound to a specific solution. They are absolutely operational in any digital landscape. And they're essentially an operational hybrid of clinical guidelines and data recommendations that are put together. And they're a way to give ministries a control over their digital products and to ensure that we have data standards that enable health information exchange between numerous solutions. So what does this look like? So they're interoperable, software neutral, WHO content. And essentially there are progressive layers across these guidelines. The starting is the narrative guideline, which is essentially a book. It looks, you know, something like this. Well, you can't maybe see it, where you have the written book on the guideline. The second level is these digital adaptation kits, which I'll tell you about. These are human readable, software neutral documents of basically the functional requirements to implement these guidelines. The L3 or the machine readable level is basically, again, structured software neutral specifications in computer code, adhering to interoperability standards to make sure that those are together. The fourth is the executable one, which are basically software that can execute algorithms as they stand and digital components to deliver the functional requirements. And then the last level is the dynamic level, which is basically that are trained and optimized with advanced analytics so that you can achieve prioritized outcomes. So at the L2, this is the second level. This is what we're developing for HIV. So these are the HIV digital adaptation kits, and essentially they respond to a number of scenarios. So first is, a country might say, I have a digital system, but I want to ensure that the data and decision support aligns with WHO norms and standards. People sometimes are transitioning from paper-based to digital systems and need assistance. So basically, the digital accelerator kits detail the data elements and algorithms that can be reviewed and programmed into their existing digital systems. They include data dictionaries, decision support logic, and functional requirements to really help start the digitizing process in a country to collect data the way they want to. And then the fourth is they really ensure standards compliance to make sure that they're mapped to standard terminology so that data exchange between different groups is facilitated. So just to give you an example of what I mean by all this. So here we create these generic workflows, and there are two lanes here. The first on the top is basically the health and facility level, or it could be a community setting. And in the bottom lane, you have the community health services, or basically a defaulter, somebody who's tracking defaulters. So at the top, you have a client who comes in, they're registered, they go through testing, they may have PrEP, they may have care and treatment, and for each of these, they would have a detailed list of what you would need to collect at what stage, diagnostics, and then you'd go to dispensing and billing, and then that support process ends. And similarly, for the community work at the bottom, you have the client who's identified for follow-up in step one. The person who's doing the follow-up, the community health worker would attempt to locate them. They would record the outreach outcome. Again, how to record it, what are the codes, what do you need, was all listed there. And then finally, you reach to all these different outcomes. So, were they transferred? Did they return to care? Did they refuse care? Or were they listed as being deceased? So moving that, so that's the digital adaptation kit. This is now the L3, where exactly that text from the guideline is included right here at the top. You have the structured logic system that I just described from the digital adaptation kit included here as well. And then you have actually the guideline listed in software code. So this would make it much, much easier for countries to adapt and use our guidelines. So how will it work? So the idea is that having these computable guidelines here highlighted in green, right away from WHO as we release the guidelines, will really speed this process to reaching the health workforce to get them the most up-to-date national guidelines so that they can implement them in their care and service to clients who come for services. And that will increase the quality of person-centered care that's delivered. And then feeding back at the top, you can see the analytics that are used to inform decision-making will also be improved and simplified. We also have these toolkits for the analysis and use of facility data for action. And these are comprehensive curriculums for national district and program managers. We have them, there are some general ones, and then we have specific ones for specific diseases that have been developed. The one on HIV is in red, and these are all available online and can be used by people who may want to start using their facility data at a regular level. I'd finally like to conclude by showing you a little bit about what we mean here. And this is the DHIS2 HIV case surveillance tracker. So what this is essentially putting what I just described into a digital tool that's usable right now. It's a way of either extracting information from the electronic medical record, or it can be entered in directly. The idea is that it should improve quality of care through person-centered monitoring over time. It should improve routine facility data and therefore the national HIV response. It's all consistent with our WHO guidelines. There are standard dashboards that speak to multiple different perspectives. They have different geographic levels. They have standard analyses, for example, the 95, 95, 95. They have disaggregated analyses on special cascade indicators, and each of these can be adapted as needed to a particular country or situation that it's being used in. We can use standard denominators, for example, spectrum estimates of the estimated people living with HIV. And importantly, and across all our WHO tools, it's agnostic to the health management information system platform. So we are software neutral. We don't recommend either one or another platform to do any data collection, but we try to facilitate as much as possible that they all adhere to the same standards. And finally, it's very flexible and customizable. So I'm going to now just show you what it actually looks like. So here is the dashboard. I hope you can see it. Sarah, please tell me if you cannot. And this is a sandbox version, so based on dummy data from Lao. And what you can see is here in this first level, you can see all the case reporting and demographic statistics, the number of new people, cases in the last month. And you can click on it. Here is from 2020 versus 2021. You can see the new cases over the year. You can look at the number of people living with HIV and on ART who were new. You can look at specifically, and you can go into a lot of detail. I'm not going to click on it now because it's a little slow to look at which district has how many cases, and you can even go through it even a little further. You can get the cumulative case counts. You can look at the total. You can look at it by age and get into those in a little bit more detail. You can have it by gender. And here again, these are by at the current period, at the last year's end. So this would be, given that we're December 2021, this would be, for 2020, but you can look at it as of today. What was your last number? We can look at key populations, where the cases by which group. We can look at more detail by age. You can have information by facility and gender and so forth. We then have these ones on ART linkage and retention, and just give it a moment while it loads. And you can zoom in again in these maps to see what are the linkage rates and retention rates, and they look fairly high. And again, these are dummy data that they've allowed us to use. And here you can look at the cumulative number of people on ART, the number of cases initiated this year. You can look at it, who was initiated within 14 days of the last test, and so on and so forth. You could also look at death or other outcomes, lost to follow-up death, or still currently on ART. And you can look at it by gender, by age, or by any other factor. And you can also look at the treatment data by facility. I'll show you one on TB just to show that you can have all these related conditions included in a fairly simple way, again, based on the standard WHO recommended indicators. And you can look at treatment initiation, treatment completion, and so on and so forth. You can look at it by adults, by pediatric, by quarter over time. So this is really changing what we can do with data and routine data. And here is this example. So this is the epidemic status, and this is the 95, 95, 95. The denominator here is taken in from the official spectrum estimate, if you look at it here. So you can immediately look and see how are we doing, and you can look at the cascade through the last year. And then finally, just to close, this is the facility monitoring piece. And so each of these people who come in and will have different levels of access for different types of data. First to enter, second to who can view which data sets and how. And at the facility level, you can start looking at some of the information, the age of diagnosis by age and sex, over what period. You can look at their treatment status, and you can generate a line list So here's one on attrition, and you can say who was lost and who was why and who was not. And then you can get, here are the cases who are not on ART in the last month. And you can also generate a line list for everybody whose appointment is coming up in the next week. So I will go back to my slides now. That was just to give you a sense of where we are. And just to conclude, to say that, I hope by the end of this, you will agree that really strengthening routine data systems improves both the national capacity to monitor and respond to health needs in real time, but also at the local level, at the facility level, improves quality of care. It also improves surveillance. It can improve program performance. And finally, by using data that are reliable, replicable over time, that it would also improve global reporting. These kinds of systems, if we put the funds and effort into them now, they are sustainable over time. They would not be dependent on external funding sources necessarily. And they're also scalable, can reach all health clinics, community-based services over any geographic regions where they're providing health services. And then finally, having the flexibility to link across the different data systems, whether that's labs or pharmacies or the logistics management information where drugs are ordered. I mean, those are just one additional step to link those facilities and those systems, to enable people who are making decisions to make decisions in advance and to see and react in real time to shortages or issues that they're seeing right away. And then finally, all this information can contribute to other surveillance exercises, whether it's trying to understand better HIV prevalence or incidence. They can contribute to modeling or other estimates. And so really, I think that this is a path to the future. As I said, many high-income countries are already doing this. We're hoping that this will be something for the future for many low and middle income settings. They're already moving in this direction. And we really hope that in a few years' time, this will be part of their regular care and treatment and monitoring. So that's it for me. I can take questions, and I have a lot of people to thank. Over.
Amazing. Thank you so much. Oh wait, let me start my video as well. Yeah, honestly, thank you so much, Shona. That was such an interesting, engaging talk. And I really enjoyed the insight you gave on what goes into sort of creating these guidelines. And I really liked, like all of the flow charts that you had, and especially like showing us the dashboard. I think that was so interesting. And I think, yeah, you also really accurately showed the importance of sort of robust, thought out and quality like indicators and health services and systems and sort of the data and everything that we use and that goes into program management and surveillance. So yeah, that was great. Thank you. Now I think we can pass on to the Q&A. Yeah. So yeah, I want to make this as interactive as possible. So if you have any questions, put them into the Q&A box, or alternatively, you can raise your hand and I'll give you the floor to ask your questions. So
I think Tom had his hand up, but I'm not sure what that was. Okay, yeah. Sorry, go ahead.
Yeah, do you want to ask your question, Tom?
Yeah, sure. Yeah, thanks, Shona. That's really interesting kind of overview of the kind of different opportunities and challenges around strengthening routine data systems. I was particularly interested in what you were saying around integrating different conditions and data on different conditions for kind of identifying prevention opportunities. And I've got a particular interest in using indicator conditions for HIV as a way to kind of guide HIV testing. I was wondering, you set out the 3 conditions that were like currently being looked at. I was wondering if there was any process for looking at further conditions and what would be the kind of evidence base and discussions around that.
So indicator conditions are, that's a good question. And I guess that question would be on what, what would you be considering? It might be, say, people who are showing up with advanced disease or cryptococcal meningitis or something like that, perhaps. And I think, what we're talking about here is just a first step, a first start to start including other related conditions. I mean, ideally, we should be including many different parts that are related to HIV, people who living with HIV or people who are receiving prevention. And that could be, say, mental health services or, contraception for adolescent girls and young women who are at risk for HIV and at risk for sexually transmitted infections. So I think other indicator guided testing is, and those conditions could be considered in the future. Possibly countries could be adapting them already to add them in. I don't see a reason why they should not be. But at the moment, we're trying not to overwhelm and say everything should be linked to everything, because then it just becomes very difficult to at least get started. So this is where we're focused for now.
Thanks, Shona.
Thank you. So we've got also questions from like in the Q&A. So I think I'll ask the first one. So the first one, so it's from Brian, and he's saying, really enjoyed your presentations, Shona, and we look forward to sharing this presentation with colleagues and synthesizing learnings across the 5 webinars in this series and sharing these via LSHTM and MeSH networks. So to my somewhat broad question, do you foresee a world where we will be able to drop the word aggregate altogether in relation to HIV data guidance?
I like the question, Brian. Thank you. I think hopefully one day, but I don't think probably in the near future, because ultimately, even though aggregation loses some information, I think there may still be utility in, for example, knowing, what proportion of people living with HIV are on ART and virally suppressed, and what percentage of those were women and men, and by what age. And so I think, ultimately we can't only use individual data. So we will need aggregate data at some level, but hopefully if it's all based on information coming from individuals over time, it will be more accurate, more reliable, and we could interrogate it further to get more details as is needed.
Yeah, great answer, thanks. So there's another question from Brian. And so he's saying, possibly a slightly unfair question, sorry. What do you think is the main barrier we need to overcome to achieve something we have known to be important for a while now, namely accurately and routinely monitoring HIV in the context of comorbidities?
It's a good question. I think, with comorbidities, it's the challenges that the world of HIV is, if you think of it as a Venn diagram, have their, priority groups and populations. You might have a similar and overlapping one, like you would say sexually transmitted infections, similar and overlapping with hepatitis, but each of them have this huge other group of people which are not related to HIV. So for example, for hepatitis, you'll have, in countries like, say, Egypt, which have very high prevalence, you would have many more people, than just people who inject drugs who may be at risk for hepatitis. So I think the challenge with comorbidities is that there will need to be their own robust surveillance and data systems. And what we're trying to do from the world of HIV is include it where we can in the HIV systems to be able to track more, better where things are going and where services are needed. But I think ultimately for the challenge for the comorbidities is that they need their robust systems, and then we have to try to start meshing them together and finding that. So I think, some of them are much further away from that situation than the world of HIV, which has had resources, for the past many years, in compared to some of the others. So for example, STI surveillance and STI data collection is really challenging. A lot of it is syndromic. We don't have good diagnostic tests, or we have good diagnostic tests, but they're not really available in many settings and places. So I think that is the challenge, is trying to bring those together. But we are trying to do what we can with the HIV systems that we have and try to build out from there. But I think ultimately those others will need to be strengthened as well, so that we can have one platform for, one health for one group of people who may have multiple issues that they are coming into the health system for.
Yeah, absolutely. Thank you. I think that definitely like collaboration and working together on these issues and like between, not just focusing specifically on HIV is very important to like move forward. So I don't know if there are any other questions. I have a few questions myself, but I don't know if any other attendees maybe have any questions. You can raise your hand and I can allow you to talk, or you can just type it into the chat. But yeah, maybe if there are none for now. So I had another question. I was wondering, so, these guidelines are kind of, they're to be adapted, like to many countries. How do you think then countries are able to like culturally adapt them to their context and to like the way that their, like the way that their systems work and also like, the way that their culture works kind of?
So I think for the adaptation process, in the past, we sort of set out some standards, and that's the whole purpose of WHO guidelines, is to have a common standard. And whether that has been for priority indicators in the past or for these guidelines, it will be sort of a minimum data set that is then used. And so the minimum data set we think would be applicable across the board to most settings. But for example, things might be different in different places, so they would adapt it as needed. So for example, adolescent girls and young women, for HIV prevention, it's a critical priority in Eastern and Southern Africa in particular. It may not be a priority for other parts of the world. And so those settings would then perhaps look at those, adapt our minimum data set or our indicators to really highlight what they want or need for those particular populations. So I think, that's part of the process, and countries and ministries of health are very good at doing that already. I mean, they know and understand their epidemics better than anybody else. And, as we come out with these standards, most times they take them as they are, but often they adapt them as they need to for their context. And it's worked very well in the past.
Great, thank you for that. That was a good answer. So I think we're kind of getting to the end, and I'm aware, Shona, that you've got then another meeting to go to. So if there are no more questions, I think I'll just wrap it up now. So thank you again, Shona, for being our wonderful final speaker in this series. And also, I just want to say thank you to our previous webinar presenters as well. So basically all of the recordings from all of the previous webinars are on our website in either sort of like in the videos tab or the updates tab, and the links for our website are in the chat. And so the recording for this webinar will be up on the website next week. So please make sure to, share with everyone so we can, keep this really interesting conversation going. And also thank you to everyone who joined and contributed to these webinars. And thank you to especially those who have actually joined all of the webinars from start to finish. It's lovely to have you here. We've had great engagement and feedback in general, and I think everyone's thoroughly enjoyed this series. And so we'll be back in the new year with a new series potentially. So also, if you have any sort of suggestions for what you would be interested in having us cover, then don't hesitate to contact us. There's a contact form on the website, or you can reach us via our Twitter or our email, which I'll just put in the chat now. It's just mesh@gmail.com. I saw there was just a last question, but I think maybe, I don't know if you want to answer it, Shona, or if I should just, if you just want to head off, since you've got maybe have a few minutes in between this meeting and the next.
I haven't seen the question. Do you want to read it to me?
Yeah.
Quickly? I don't see it.
So it's basically, so it's from Mitzi Gavos, and she's saying, thank you for a great presentation, Shona. Apologies if I missed this. How can we monitor key populations accurately in relation to the data approach you presented? And how can we use routine HIV data to enhance our understanding of syndemic interactions?
Thanks, Mitzi. I think the key populations one is an important question, and we really should be doing this already. So I think in fact, when we started doing this review to look at what we want to do with routine data systems, the key POPs ones are already doing this. So it's often very program focused, program specific. So for example, groups that are following men who have sex with men or sex workers, they already have fairly robust key POPs follow, longitudinal systems that are following their clients over time. So I think these certainly can and already are being applied to key populations. I think one should be able to do this even in a general population setting, because obviously there are key populations within even those settings. And so I think we want to have a general approach at the health system level that captures individuals who are coming in, as well as for key population specific programs. So absolutely, it's a great point, but and I think we should be heading in that direction wherever they show up. And I think the second part is understanding the syndemic interactions, and that's where that point about the comorbidities or other related conditions comes in, because I think we will start picking up and seeing issues related to, say, syphilis rates in people taking PrEP, or other situations like that where you would have, different cervical cancer. I mean, for cervical cancer, there's such little data for women living with HIV that I think if we start to push that agenda and start, collecting more, we'll start seeing more and being able to answer some of these questions on, say, treatment, recurrence, reinfections. And I think, having systems that talk to each other across diseases is really critical. And I think ultimately that's where we want to go with, universal healthcare, and how to do it, though, is a stepwise approach along that pathway. So it's one step at a time, but I think that's the direction we all want to go in, and countries are absolutely excited. They're interested. We're inundated by requests to get moving in this direction. So, I think we're forward looking, and we'll see how things pan out in the future, but I think that's the direction we're going in. And many ultimately, diseases and syndemics, we'd be able to track and look at patterns for surveillance much, much better than we're able to at the moment, rather than being reactive. Over.
Great, thank you. That was a great response. Right, so we're at the end of our time. Thank you again so much, Shona, and thank you to everyone who joined. And yeah, good luck with your next meeting.
Thank you, Sarah, and thank you all for the opportunity to present, and looking forward to doing more with you in the future. Bye.
Thank you.
Thanks,
Bye.
everyone.